Well, welcome everyone. It's my pleasure to host today Alessandro Vespignani. He's professor at the Network Science Institute in Northeastern University. And he has been working for several years on digital epidemiology and also in general in complex systems. So he has been very active modeling the spread of disease, not only with COVID-19, but also with Zika, with Ebola, with influenza H1N1. So he and his team have really lots of experience on epidemics and pandemics. So please, Alex, we're very interested to know what you want to share.
Thank you very much. So it's a pleasure to have this chance to engage with your community, and I will start sharing my my screen so that I can run the slides. And I think if you can confirm that you see clearly the slides, that would help.
Yes.
Perfect. Okay, so I will talk about what work has been done in the area of computational epidemiology during this long 1 year, actually, for people doing modeling and engage with agencies. It started at this point almost 1.5 years ago. I will first of all, I have and must acknowledge all the many collaborators. What I will show is not, you know, one person, one team, but actually really the work of many times, many individuals, many collaborations, Northeastern University, but as well, you know, several places in the US, Europe, and also the private world like Cubic who provided us data, and I have to really thank to all the people who are basically in this marathon against the virus since many months. Let me start from a very simple consideration. I always like to show this kind of parallel between numerical weather models and numerical epidemic models. If you think about weather prediction in the way that we know nowadays, we go back to the 1920 when Richardson integrated manually the equation of the atmosphere in order to get a 24-hour forecast for one temperature and pressure point on the map of UK. That was an incredible amount of work that lasted months for him. And actually the results were not encouraged just because he was using equations that were too sophisticated for the kind of data he was handling at the time. But it was really the visionary that started to say, okay, we can do weather forecast by using mechanistic models of the evolution of the atmosphere. Yeah, the same years, basically, the Reed and Frost defined the first simple chain binomial model of an infectious disease process. It was a very simple SIR model that they actually, to simulate the stochasticity, they were really taking red and blue balls from an urn. So they were, how to say, simulating the stochasticity that way. But you see, the two things are early attempt, mostly aligned. And then in 1950, there was the first numerical weather forecast done on a computer in Los Alamos, 24-hour computation for a 24-hour forecast. So you would say completely useless, but actually this was the proof of concept of really able to do a forecast. And 2 years later, just, you know, there is the first Reed and Frost numerical implementation on the same computer. So the two things seems, oh, well, good aligned. Instead, you know, numerical weather models have a sprint, and in 1955 they become basically operational. in the United States. And if you think since at this point, almost 20 years, it's not just a matter of national centers, but, you know, government and commercial entities routinely have forecasts that, you know, are at your fingertip on any mobile device. Instead, if you think about numerical epidemic models, you have to, how to say, wait until the 1980s, 2000 to see progress toward the more detailed, large-scale individual models. In 2005, with the scare of the avian flu, there is some very large-scale agent-based models with really ingest realism into them, and then, you know, we need to get to 2015 for operational test of forecasting with epidemic models. So what is the difference? Well, the difference is basically in data availability. We send satellite in orbits. We have built a weather station across the world. Well, we didn't do exactly the same for mapping, you know, individuals in their whereabouts, also because of technical difficulties. So obviously, you know, doing experiment in natural sciences is different than doing experiment on populations or acquire data on populations. And so, you know, for many years we really didn't have the detailed data we needed for making certain modeling approaches, to build certain modeling approaches. In the last 20 years, there have been a deep change of state of the art due to what has been called the big data revolution. So we get gene sequences at a fraction of a cost every year. We have mobility data that comes from digitalization of databases, as well as mobile devices, traces, and you know, this is really unprecedented. And then we can use machine learning and different data sources to get very detailed map of population, like, you know, the one that we do by combining the census data with light emission captured by satellites and so on and so forth. So all this is changing the landscape, as well as, you know, what we call the novel digital data streams revolution. So what is that? Well, we don't have just, you know, those data about where we go physically or where we meet and all the public health data that are crucial for obviously for infectious disease modeling and health modeling. But, you know, we have no digital stream like for instance, participatory platform like Flu Near You, that is an initiative that with volunteers that upload on the system, you know, their symptoms with respect to flu, the visit to doctors, etc., provide a kind of live sentinel systems for influenza. And there are many of them. We say those are active data collection systems because they need the engagement of participants, of volunteers, and obviously, you know, is part of what we call citizen science in a way. But then there is also a lot of passive data collection. So we leave infinite traces in the digital world at a level that we don't just can get, you know, the fact that you have fever or the flu because you write a message on that, but we can enter, you know, what is your attitude with respect to vaccination. We can look at millions of individuals and basically enter their thinking, and that's completely innovative. Those are data which are, how to say, dirty, not collected for any public health perspective or problems. And so we have to be very, very careful, but they are going to, and they have been complementing a lot the public health approach in the last few years. Well, this kind of data enters, you know, and digitalization are part of the big narrative framing of big data in a sense. And then more recently, artificial intelligence and as a solution to all the problems. And perhaps some of you remembers an editorial on Wired about 12 years ago at this point that was called The End of Theory. So this editorial was saying, you know, at a certain point we will have enough data that we will throw those into some artificial intelligence algorithm, some machine learning approach. We will get all the information we need. And we don't care about having a theory of what is the process or a mechanistic understanding. You know, we just have the answer. And you know, the article was had a last sentence that was really a provocation. He was saying it's time that science start learning from Google. So that was, I would say, not always well received in the science community, but in a sense it was one major idea was a kind of poster child of that vision, you know, and is what many of you know as Google flu trend. The Google flu trend was a stroke of genius in a sense. So, you know, the Center for Disease Control in the United States every year collect a large amount of data from a surveillance system made of hospitals, doctors, etc., about flu-like symptoms in patients. And then all those data are aggregated, weighted, et cetera, in order to provide an analysis of the impact of the flu season in the United States. As you can imagine, this process is not just time-consuming in terms of resources and people, but is also always delayed. What is the situation? The picture of the situation that you get is generally 2 weeks behind where you are, just because of the time to accumulate data and treat the data. Well, Google Flu Trend was this idea to say, well, guys, millions of people do searches on our search engine, and we can capture searches related to keywords like cough, fever, flu, etc., and get a proxy signals that we can throw into some smart artificial intelligence algorithm that learn from how to rescale this signal with respect to the ground truth of previous years from the Center for Disease Control, and then can provide a real-time assessment of what is the flu season. And actually, with a bit of trick here and there, actually, we can also do forward projection of 1-2 weeks. Well, this system initially worked very well, and then at a certain point instead had a lot of hiccups, and it was terminated a few years ago. Why that? Because, well, you know, when you have an approach like that, there are several potential pitfalls. The first one is obviously the lack of micro-level understanding. So there is a black box effect. The fact that you are able to, project what will be the number of flu cases in a few weeks doesn't tell that much about a lot that you want to know about the epidemic. So what is the level of adherence to the vaccination campaign? What is the transmissibility of that flu strain? What is the incubation time, et cetera, et cetera. Many things that really you need also to work in terms of containment, hospital preparation, etc. And this is missing in those approaches. The other thing is that there are intrinsic biases, data incompleteness, noise, as you can imagine, at a very high level, because these data, search on Google, are not collected for public health perspective. The other point is, many of those approaches work on the assumption that more data means better modeling. Well, for instance, if you have a time series of the temperature in a specific place, the more you can collect those data, and the better you will have an algorithm that is able to provide you certain level of forecast of the temperature, because we have seasons, we have specific patterns, and so on and so forth. But when you talk about the health problems, the health system is changing on a time scale that data of the flu from 6 years ago might be not not representative of what is going on now. And so learning from those data actually might even deteriorate your rescaling and prediction in the current times. And then there is some more important technical points that is really related to the Poincaré recurrence theorem in high-dimensional dynamical systems. So you really need to have a smart way to do the dimensional reduction if you want to understand the problem, and that it's not always, again, going back to the black box effect, easy to do in case you do not understand the mechanism of the problem. So, well, this is not to say that Google Flu Trend was not a stroke genius, as I said. Google Flu Trend was a success, although it has been discontinued, because, well, first of all, it taught us how to use surrogate signal like, Google searches, and actually prompted to use a multitude of signals. That is not just Google searches, but Twitter, Wikipedia, insurance claims, even data from OpenTable, that is a restaurant reservation system in the US that last minute cancellation in this system correlates very well with the flu season, as you can imagine. And we can be much smarter and create much more stable systems based on proxy data. The other thing is that it brings the full power of artificial, as this experiment has brought the full power of artificial intelligence and machine learning in this public health forecasting business. And indeed, if you look at the Center for Disease Control yearly flu challenge, that is basically a system that is called FluSight now, to perform routine forecasting surveillance for flu, you would see that many systems are indeed based on computational techniques that are complemented by signals like the one of Google Flu Trend. So, it was a success, but at the same time, we need to understand that we need more than that. And we all need to complement these new methodologies with old methodologies and mechanistic understanding. This is particularly acute in situations like the one of COVID. We don't have training data early on. Reporting is changing. Probably some of you remember that in March, we had so limited tests available that it was impossible to capture what was the number of cases in any place. But that this has been changing continuously, and the kind of test, the case definition, a lot of heterogeneity. Many do not know that even now, the deaths that are reported today have 1, 2, or 3 weeks delayed, and refers basically to the past. So all these things are complex and have to be dealt with in a way that is not just at least initially learning from historical data that are not available. So what is the point here? The point here is that I want to really make the case that we need actionable modeling. And actionable modeling means models that we can use for actions, for policy making, for understanding. And this actually can and should lever on all possible data, big or small, new and old. But there must be some key points. First of all, we need interpretability. We can combine mechanistic approach with machine learning and artificial intelligence, but we need to have some understanding of effective equations, the uncertainty produced by initial condition and predictive limits, et cetera, et cetera. So we want to go from time series to something that is much closer to what is modern weather forecasting. So where we have hurricane trajectory that are forecasted, as you see, with geographical resolution, with time changing, with a clear understanding of what is the uncertainty that we have in the predictions. Well, that means that we need to start, however, in terms of epidemic modeling, a journey that goes from the simple to the more complex and embed the complexity of the epidemiological problems. So most people knows well at this point, especially after this 1.5 years of COVID, what is an SIR model, a susceptible infectious recovery model, no? But generally, all the approaches are based on homogeneous mixing. This is not enough if you want to have actionable models. So you can get some understanding, you can get some feeling, but you need, for instance, to introduce social structure. You need to have age stratified models. You need to have contact patterns. You need to include the fact that there are heterogeneous agents and individuals in the population. You need to bring the multi-scale dimension of the problem. What happens in Mexico City is not what happened in New York, and the links between different geographical areas are due to the mobility of people among those geographical areas. And then you can go to the synthetic reconstruction of populations that, in a sense, creates synthetic societies in the computer where you can play with experiments that are not otherwise feasible in the real world, like testing, for instance, some containment strategy or policy. Well, let me say there are different ways that this can be achieved, and what I will show to you is a framework that is based, however, on something that is common to many disciplines, from chemistry to physics and many others. So that is reaction diffusion on a network. What does it mean, reaction diffusion? Well, it means that you can model a population where the nodes of the network are specific places, could be urban areas, could be states, countries, etc. There are individuals, those are the particles in a sense, the individuals, which are labeled with all their attributes and then the various stage of the disease. And those nodes are connected through mobility data. So basically, instead of having the usual random diffusion that in many cases are used for physical systems or in chemistry, you know, we have that the movement from one population to another are according to specific data that are coming from the real world. And then within each population, we have that people can meet, can interact, and then there is the dynamic of transmission of the dynamics that is generally a stochastic dynamics. There are a lot of stochasticity in all this process. But if you want to go back to the bare bone of the modeling framework, is a reaction diffusion on a network. Well, let me give you a little bit more of an example of what this means. We have here the United States, and you see the multiscale framework that we build is a multiscale in which there are different layers. And the first layer is the population with all the socio-demographic attributes. Then there is a community networks that connect short-range mobility, the daily whereabouts of individuals, in the geography of the system. And then we have, you know, also domestic and international connections. And then you have to basically repeat this description across the world in order to create a connected system of locations. Each of these places is a specific geographical resolution on the map that is a node with its own population, and then, you know, is coupled through the mobility of individuals, and that can be the carrier of the disease, and then the basic dynamic describing the disease. Well, here you see that we go from one scale to another, in the sense that obviously, the computationally, you might find some problems in terms of modeling in a detailed way 7 billion individuals at the level of single household might be an issue. So what we use is multi-scale approaches in which you can use different resolution at different geographical scales, so that you can achieve the desired level of precision. Here we go from methodology that are more closer to homogeneous mixing, although they have to contain mobility data flows coming from real data. Then you can introduce age structure, specific agent-based model, multiplex representation of the population that are very extremely detailed, and so on and so forth. And that depends on the geographic resolution at which you are looking at the problem. Here, however, I want to just state that all that, because you say, well, but you are building a monster. You know, this monster, however, is based on data. It's not based, you really need to have as little assumption as you can. For instance, what we use is microcensus data, in which there are single households mapped. Those data, which have a huge amount of information on the population, and they're used to reconstruct, respecting the macro statistics of each place a synthetic population that is statistically equivalent to the real one, but you don't have the problem of privacy and issues like that. The same for the mobility data. We can go down to the level, as I will show you later, to which restaurant you have been, but you want to anonymize and put all that in a stochastic statistical perspective, so that again you are looking at a statistical description of a population. What you do is to create agents that have connection. Those connections are statistically equivalent to the one that you find in the real world, in the different layers of the real world, like the household, the school, the workplace, the community, means when you go shopping or to a movie theater. And then you can decide for different resolution. You can work at the network level, you can work at the mesoscopic description, in which you create sort of coarse-grained network, in which you say, what is the frequency of contact between individuals of a certain age with the individuals of another age? These are what we call age-stratified contact patterns. And again, you can look at different settings. In this synthetic world, there is the infection transmission model. The infection transmission model, that is compartmental, but doesn't mean that you have the compartmental homogeneous model. Disease means is the natural history of the disease of each individual and the way it goes from one stage to another of the disease. This model, there is specific to any specific disease, and there is no model that fits all diseases, is built and adapted according to the resolution of you are working with. Well, let me say also what you do once you have built these systems is to start for sure with a number of assumptions that are due to the poor or incomplete knowledge of initial conditions. In December, we didn't know exactly how many cases were there, and so on and so forth. There are parameter uncertainties that get narrowed down, but initially, what is the transmissibility? What is the incubation time? What is the latency time? And so on and so forth. Plus modeling assumptions that comes from, the fact that you might have better refined data or not, and so on and so forth. And so then you have the stochasticity of the system. And for this reason, what you do is to generate essentially a huge amount of modeling trajectories, and that inherently define an uncertainty cone. What you do is that each of these stories will produce a different future. These are kind of possible map of the future. And then what you have is that you assemble that to get probabilistic vision of what could happen in time. And then this cone is becoming larger and larger the more you project and the more you make assumptions. And this is all the problem of defining what is the time horizon at which you can work with specific models. Well, I talked a lot, and we talked a lot about, and we think a lot about forecasts, but we need to keep in mind that model is much more than forecast. There is situational awareness, intervention planning, projections. I will try to define the differences. Epidemiological explanation. So use modeling when you have data to find meaning in those data, and then epidemiological explanation to what you are observing. And then for the structural reasoning, that means all the counterfactual scenarios that you can use. I really suggest reading this paper that is cited here in National Academy of Science. This is a paper that we wrote for these same reasons about modeling, but in 2014 during the West Africa Ebola outbreak, just to show what is the importance of modeling in that context. Well, let me give you a few examples of these in the area of COVID and the work that has been done in the past years. Well, when we started to have a warning from the WHO in China, we are talking about a handful of cases. And why we had a handful of cases? Well, because actually there was no way to test people. So really, obviously you are just looking at the tip of the iceberg. So the first problem in a emerging infectious disease outbreak is to try to understand, okay, what is the real magnitude of the outbreak? And when it did start, that is the second question in a way. Well, this is something that models can do pretty well without even assuming too much about the disease dynamic, because you can use, for instance, mobility data And at the moment that you start to detect the disease outside of the origin of the outbreak, you say, well, there are 2 cases in Thailand and 1 in Japan. That is the moment that we started to work on this kind of calculations. Is it possible to use mobility data to basically back calculate what is the magnitude of the outbreak there? Basically, you have a certain probability of exporting people. And if you start to observe a certain number of exportation, you can say, well, on average, I need to have that many cases at the origin, and then by using some approximate Bayesian computational approaches or other approaches, you can get a kind of prior posterior distribution for what could be the magnitude of the outbreak. Well, this is what was extremely important initially, because immediately from the very early stage of this epidemic was clear that there were thousands of cases in China when they were just declaring a handful of them. And then by the 20th of January, we were talking about tens of thousands of cases. And so this obviously rules out the fact that there is no human-to-human transmissions, raises a lot of flag, and so on and so forth. The second thing that you can do, and this is situational awareness. So you are trying to understand what is on the ground, because you have still data which are not able to capture the real situation on the ground. And then there are a lot of situational awareness by producing, for instance, map of risk for different areas in terms of importation of cases. What is the likelihood that those places will observe cases in the future? This depends on the travel volume, and you can work on this. We produced lists in the early days that actually we were really observing cases going down this list pretty much like it was in those estimates. As soon as you start to have more information on the disease, you can look at generative modeling approach, and this is where you start to develop models that takes into account fully the details of the disease, like the latency, the pre-symptomatic infectious, asymptomatic infections, etc. And you can try things that enters again preparation and situational awareness, like, okay, what is the effect of travel restriction? What is if we have a travel ban from one place in China, and where we are with the epidemic? Yeah, this is something that again we did initially during the outbreak, and you see that initially most of the importation through the various places of the world were coming from Wuhan, the epicenter, but then there was the travel ban that shut down travelers from there, and you see that actually other places in China were starting to take place to replace Wuhan as a source of importation, because other places were having an outbreak. And so what happens is that we have been in a kind of merry chase with respect to the virus, because then, okay, let's do travel restriction to and from China. But at this point, the modeling was showing that actually there were enough cases already that traveled around the world, that were dispersed around the world, that were starting transmission in different places. And so you can try to reconstruct this network of what we call the cryptic transmission of the disease, when there is not enough testing to test everybody with symptoms like COVID that are very similar to flu. Remember, in the Northern Hemisphere, it was the winter. And at the same time, you have travel history-based testing. So we were testing just people coming from China, while at that point, people were coming from Europe, from other countries in Asia, and so on and so forth. And so creating a network of importation of cases that were given then to transmission locally that was changing the dynamic of the disease. And now this is some part of the work that we did in reconstructing this network. And here you see that for the United States. You see that China contributed only initially to some of the state in terms of importations, but then other importations were coming from Europe, other countries, Asia. But you see, most of the importation of the disease in many of the states, especially the one that received the SARS-CoV-2 at a later stage, was domestic importation. So these were outbreak already started in some big transportation hubs that then were bringing the disease to other states in the US. Well, the model at that point allows to reconstruct what is the cryptic phase. And, you know, models, at least our modeling is telling that, you know, when we had just a few cases detected in the United States, in many cities around the United States, we had tens or hundreds of infections per day. And also, if we look at other countries like France, Germany, Italy, we see that by mid-February, there is a very large probability of local transmission. That means that this is in mid-February, the modeling, and not just our modeling, but many models were pointing out to the fact that the COVID-19 was going to be a pandemic. Well, to the level that, you know, you can put some numbers down, and when there were 23 confirmed cases, you see that actually in major urban areas in the US, we had thousands of cases. Now, you know, now you understand all that. The COVID in many cases is asymptomatic or mildly symptomatic before you start to see the wave approaching, as we have experienced many times this year. You have to get, you know, well into the exponential growth stage of the epidemic. At that point, you start to see the overwhelming of hospitals and emergency rooms. But, you know, actually there is a large stage of the early epidemic in which this is not happening, and you have this silent spreading that unfortunately is difficult to capture unless you have enough testing. This is a problem, by the way, also with the new variants of the virus. Then there is scenario analysis. I want to be short here because I see my time is I don't want to talk too much, but you see that scenarios are not forecast. So what, and I think this on the media has been misrepresented many times. Scenarios are based on assumptions. So if you hear someone tell you in the next 3 months, in the next 6 months, or you have to ask, okay, what are your assumptions on social behavior interventions, policies, et cetera, et cetera. What initially has been done with the epidemic is to define scenarios and say, well, first of all, what is the worst case scenario? This is called the benchmark or baseline, although baseline seems bad because this is a scenario that is what we call unmitigated. So the epidemic is let rip through the population in order to see if the disease hit a point in which, you know, the healthcare system is overwhelmed, the number of deaths is in excess, and so on and so forth. Why we do that? Because you would say this is completely unrealistic. Yes, it's completely unrealistic, but allowed to benchmark the risk. Because perhaps you don't remember, but in 2009, after a few initial weeks of the H1N1 pandemic, no one did lockdowns or shut down the world because, you know, even the unmitigated scenarios were not driving the system to the brink of a collapse. Then also you need this scenario so that you can produce many other scenarios where there are interventions, and then you can benchmark the effect of those interventions and then study layering of those interventions to produce combine containment and mitigation policies. So this is what is important. All the how to say, crisis unit and task forces were not acting on the worst case scenario. They were acting on a portfolio of possible scenarios and future that then you have to calibrate with your resources, infrastructure, economic possibilities, and so on and so forth. And so at the end, you know, the policy making is much more than just the modeling. And it is important to say, scenario modeling is a piece of information to the policymaking, but it's not policymaking. It's two different things. Yeah, and scenario analysis can go down to a level that is very detailed. For instance, we went down to the level of single urban areas by collecting data for millions of individuals on their trajectory, where they go, what places they were, so that we can, you know, we were able to stratify where transmission was occurring before the lockdown, after the lockdown, and so on and so forth. This was made thanks to data from QBIC, that is a location intelligence and measurement company. These are anonymized data, as I say, stochastically, statistically equivalent to the real one, but not, with any privacy concern, but allows to look and reconstruct networks of interactions in different places of urban areas. And so this is where you can go and be very detailed in designing possible scenarios of interventions, like, contact tracing, testing, and so on and so forth. The final part is the actual forecast, and the actual forecast is something different, because the actual forecast is a much more limited time horizons. It's 2 to 4 weeks, and is based on the actual current knowledge of what are the policy of intervention. You have an understanding of what will happen in the next 2 or 3 weeks. You have to constantly update those projections with contact matrices, school closure, that changes because of school closure, smart working, lockdowns, etc., etc. So this is the most computationally expensive part of the job, because it has to be repeated every week, in a sense. At least there are some models that work even by reformulating forecast every day, and they are based on very detailed data of mobility, like again here are data that provided by QBIC, which can really look at contact duration of typical behavior among individuals at different geographical resolution, the mobility, and the models really takes into account and digest in real time those information. So this is what is an example. You calibrate the model on the historical data, you have a lot of in-sample data points, and that allows you to have better estimates of the posterior of the parameter you are using, and then you have an out-of-sample prediction that is generally 2 to 4 weeks, because before the confidence interval becomes is too large to be meaningful. And here you see, for instance, something that we did in the United States right before the big peak in the fall winter. Actually, this is where computational implementation is very important. Computer science enters the game. We need high performance computing and high performance data analysis. We were able to do most of our work because of a partnership with Google that allow us to really have, in a sense for us, unprecedented computing resources. And this is also where artificial intelligence becomes very, very important again, because you can define hybrid modeling approaches in which you can augment the reality for mechanistic model through machine learning. You can use machine learning, actually models, mechanistic models as a proxy for the machine learning approaches. And then you can use machine learning for optimization and parameterization of the mechanistic models. And then there are a lot of work that has been done during this pandemic. For instance, we have 2 models now, one that is fully mechanistic and another one that is the mechanistic model plus a deep neural network that try to evaluate better the uncertainties that cannot be described by the epidemic model itself, like delay in reporting, issues during holidays, there are other kind of structural delays in number of deaths and cases reported, and so on and so forth. And the machine learning can be extremely good at providing better confidence interval. Now, I'm really going to close 2 just observations. The first one is that these are models, and they have not to be considered in question oracles. So computational epidemiology is based on model, it's not the reality. So provides a range of possibilities based on facts and data on the ground. The other thing is that don't listen to the single modeler. Just always use what has been taught again by weather forecast ensemble models, where many models are aggregated together, ensembled, in order to provide more stable forecast, predictions, and analysis. You need consensus, and that is crucial. This is what we do with the national forecast, with the Center for Disease Control, where now there are more than 20 models. We are doing the same exercise for long-term 3 to 6 months scenarios. So you work with a portfolio of models. And this is also happening, for instance, for Hurricane Path, where there are several models. Each of those spaghetti that you see is a different models, so that you create better confidence interval and aggregation. And multiple models output, I think, is really going into the future in creating a infrastructure that are able to be game changer for future pandemic and epidemics. And you see, this is there are a couple of pointers here to one experiment exercise that is called modes, the forecasting hub of the Center for Disease Control, where there is a lot of discussion and a lot of science, how we ensemble models, how we define confidence intervals, how we evaluate the performance of models, so how we plug these into the policy making. So there are enormous scientific questions also of a fundamental and foundational nature. And this is my closure, really. You know, what I've shown to you, it's a lot based on what we call wartime. So actionable modeling during an emerging health crisis. And, you know, it's important to have that, to see that epidemic modeling is relevant beyond the conceptual or stylized models. But at the same time, you know, it's important to keep in mind that epidemic model is important not just because we have a lack of data, but in some cases because we have so many data that the models are a key to get that epidemiological understanding, the counterfactual scenario analysis, and so on and so forth. And finally, really, applied outbreak science, as all applied science, is the opening for new foundational science problems. I think COVID in this area has provided so much new foundational science problems that for many years we'll be working on that. Hopefully we will not have to manage another pandemic. And so we will just prepare and understand better what is the world out there. Thank you very much.
Thank you very much, Alex. Well, for questions, please type them in the YouTube chat and I will transmit them to Alex while we receive them. I have already several questions. So first of all, when was the moment that you realized that this was big and grabbed the phone and said, Atlanta, we have a problem?
Well, for us was quite early. I think for many of the people like me that were in touch with the international agencies and started to talk, it was clear that we had a major problem second half of January. And I would say that it was pretty clear. I started to, how to say, to move and talk to people about the pandemic in early mid-February. So that's the time scale. I remember the first times that I really went to somebody saying, you know, we have to prepare for shutting down, lockdowns, etc. And it seemed surreal to me when I was saying something like that. I was saying, "Oh, come on, what I'm saying." You know, it's at that time we were not seeing anything. You know, the hospital were business as usual. We didn't have cases, but we were already ringing bells.
But you started hoarding toilet paper anyway.
Yeah, well, you know, because we had to do. That was the way, you know, for us. Yeah, it's our first paper, I think. Yeah, was submission was in January, because the numbers were, but you know, it's not just me, the entire community. When Mark Lipsitch and his team published the fact that, you know, only probably 20 to 30% of the cases were detected internationally, it was clear that you know, things were going to be a major problem. And so that's the timeline. Yep.
So Caroline Weissner asks, what's an example of a new foundational science problem that you have encountered during the last year while modeling epidemics?
Well, you know, the first one is really how to merge phylogenetic networks with modeling with basically the invasion network that we get from mechanistic models. Both approaches have their their limits and issues. And I think the future is really to get more, how to say, again, hybrid systems in merging those two approaches to get a better description and possibly an earlier description of what could be the international and geographical spread of diseases. There is the point of understanding more clearly all the effect of super spreading events on large scale models, and at which scale they are relevant, at which scale they are less relevant. There is the issue of how to really provide ensemble approaches that work, and what is the model selection that we have to perform, how we can create this multi-model exercise in order to generate something that is, you know, when you have the weather forecast and the hurricane, you have the National Center that is providing some forecast. You don't have single individual modelers, you know, shouting and crying here and there. This is my model. This is my results. This is my, yeah. So we need to get there. We need to get into this mature stage, and that there are several of those issues. There is problems that are really foundational, like what is the concept of a reproductive number in heterogeneous population, heterogeneities and how they affect, you know, most of our understanding still comes from fairly homogeneous picture of what is the system out there, and they can be misleading in some situations. So there is really a lot.
Yes. Alberto Garcia asks, in your talk, you mentioned how to generate models with big data. What would it be when you have scarce data with significant delay in the data, or just few PCR tests and so on?
Yeah, I you know, there are scarcity of data, although we are in a big data era, and you would say, oh, well, we will have the best data on cases and deaths and where everything is real time. No, it's not like that. So there is a lot of science to try to overcome those problems, to introduce delays, to introduce missing information. That's part of all the sophisticated statistical approaches. So there is a lot of that can be done, a lot that can be researched. And there is a lot of preparation. We don't want to reinvent the wheel every time. So there is a lot of data about population, socio-demographic drivers that can be collected in advance. We need to have more data, for instance, on human mobility that can be pipelined into modeling right away. Instead, you know, we have to invent the wheel in some cases here. And I hope that we will go into a future where we will have permanent frameworks and institutions that will take care of setting up systems that are, you know, there and are operational. That's very important. A large part of the effort of the in terms of modeling and data analysis for this epidemic has been left to the academic world, but the academic world is not structured and meant to support something like that, especially for 1.5 years. So we need to change this. We need to have national center in each country for outbreak response. They can be used in many other ways, and they have a lot of work to do and to foster, you know, to prepare for events like this one.
Yes. Also, I mean, your experience, how might be the best way of dealing with decision makers? I mean, not only politicians, but for example, business owners, meat packaging owners, school principals, and well, in general, with the general public that disregards science because it's against their beliefs or interests to take necessary measures.
I think there we enter another area that is extremely important, and is not just the modeling, but it's the connection, the interface between modeling, forecast, data analysis, analytics, and the policy-making world. This is not something that you invent from day to night or from night to day. You really need to have a dialogue, you need to have trust, you need to have people at the interface that are able to communicate the different expertise and to the different expertise. modelers might enter the room, the crisis room, in the very wrong way, and policymakers can get the models in the very wrong way. So it's important that we all know what to do. And unfortunately, there is not a lot that prepares you to situation like this one. And I think miscommunication were often. We need to have a world that policy making that is able to really understand the value also of these numerical approaches. Let me give you the example. When you have a hurricane, you know that those predictions, those spaghetti models, they will never tell you exactly where the hurricane will land and which strength the hurricane has. There is always an 80% that there will be a last minute turn, whatever. But everybody acts upon those predictions, and they are well aware of the uncertainties and everything else. Why? Especially because in that case, you have a very big ominous photo from a satellite of the huge hurricane that is there. Now put yourself in a crisis room in which you don't have the picture. You have some modeling results that will tell you, look, in 3 weeks, your hospitals will be overwhelmed. But there is no picture, no cases, no one that can say, yes, it's true. So for the policymaker, that is difficult. This is why, in some cases, it was hard for us to convey the message initially. Well, this is where we need to have this dialogue. We need to have people that trust the models. We need to have prove that the models work. We need to have success stories. We need to have all that in order to have a process that works the next time and is more efficient, for sure.
Yes. Johan Fernandez asks, should the models comply with design restrictions in order to ensure that the ensemble will show a suitable forecasting performance?
Sorry, can you repeat the question?
Yeah. Should the models comply with design restrictions to ensure that the ensemble will show a suitable forecasting performance?
Well, you cannot just do whatever prediction you want. There are some standards, and here is another thing that is much needed in the field. So we can just think to say, well, let's get 40 modelers, each one produce something, and then we get an ensemble. No, this has to be done where, the models have to be standardized in terms of format. For instance, for the CDC work that we do, we have to produce data on a weekly level with a certain number of percentiles, the median, the point estimate, etc., for a certain number of quantities, a certain geographical resolution. And this has to be, this is a definition of a state of the art that has to percolate through the community and define the best way to, to really contribute to these efforts.
Yes. Guillermo Romero asks, are you including the generation of new virus variants in your models, and what challenges do you see in this regard?
This is a very interesting and timely question. As you know, since December, we had those proliferation of variants of concern. That means variants that are more transmissible and tend to take over the wild type. So the wild type would be the old variants. Yes, in the model, what we have been forced to do is to add different strains. And so we are considering now in our more recent model in certain places locally 2 strains, wild type and the B117 variant. For a global model that we do, we include 4 variants at this point. We have also one that is a variant emerging in South Africa and one variant that has emerged in Brazil, the P1 and the B1135. So, and that make the modeling heavier, because if you think about those compartmental definition of the disease, that means that we went from something that was closer to 100 compartment to now we are over 600, because each strain has its own compartmentalization and natural history. So it's a challenge. is a challenge also because there are not that much data, again, to calibrate models, because the sequencing is very limited, and so we don't have real-time monitoring of the prevalence of each variant, and that is an issue. Another thing we are advocating strongly is to strengthen enormously the phylogenetic and sequencing capabilities across the world, not just in places like UK or other places, but really globally.
Yep. And one final question. What are the different scenarios that you can envision for the next few months, and which ones might be more or less likely?
Well, you know, unfortunately, at this point, there are three forces at play. One is the variants, which are more transmissible. The other one is the fatigue in many populations. So there is a relaxation, whatever it happens, there is a relaxation of mitigation policies and social distancing. And instead, there is the other force that opposes those two, that is the vaccination campaign rollout. Each country will have trajectories that depends on how those three forces are at play. For instance, United States, we see the effect of the B117 and the relaxation of distancing and mitigation policies. So we expect to have a rebound in number of cases, but since the vaccine has already covered and is covering more and more the population at risk, we expect a decoupling between the number of deaths, the number of hospitalization, and the increase in the number of cases. So we will have a rebound, but we do not expect a major wave in terms of deaths and hospitalization like we had in the fall and winter. Europe is delayed with respect to in terms of vaccination, so there we will have more bumps on the road, possibly. Places then we start, each country really should be discussed one by one. Mexico is doing his effort with the vaccine, but as well the number of cases is still quite elevated. There are places like Brazil that in a sense seems to have dropped the ball at a certain point, and that whether if you let rip the epidemic through the population at a certain point, you hit a protection because of residual immunity, as we say, and so on and so forth. So for sure there will be improvement in many countries, especially where the vaccine will be available. The issue is that the vaccine is not available to all countries in the same way. And we are not out of this until we are all out of this, because, you know, every place where there is the possibility of emergence of a new strain that could evade even partially, the vaccine protection is a menace for everybody. So this has to be clearly in mind of the policymakers. We need to think now for the last mile, we need to think globally.
Yes. Well, thank you very much, Alex, for a very interesting and timely talk. In the next colloquia, we will have Caroline Weisner, Melanie Mitchell, Ricardo Soler, Philip Bolt, Takashi Kagami, Jessica Flagg, and many more. So be sure to join us. Thank you very much.
Thank you very much for your hospitality. It was a pleasure to talk to you, a pleasure to be in such a distinguished line of speakers.